Good day, we are Acain, ang Bagnol, Esguerra, and Sorel presenting our poster on pulmonary atresia with intact ventricular septum, or PAIVS. PAIVS is a rare congenital heart defect characterized by abnormal narrowing or closure of the pulmonary valve, missing connection between the pulmonary arteries and right ventricular outflow tract, or RVOT, and intact ventricular septum that keeps the left and right ventricles separated. Due to the disrupted RVOD flow, a different source of pulmonary blood flow is needed for survival and is often the basis for interventions, which have been found to increase 5-year survival rate to upwards of 80%. Having said that, the study's main objective, therefore, was to compare the normal embryological development of the heart with PAIVS. It also aimed to explain the developmental abnormalities and pathophysiology of PAIVS, as well as highlight its clinical significance by discussing symptoms, diagnostic approaches, and treatment options.
So before the heart of an embryo develops, it gets oxygen passively from the mother's placenta. However, at some point during its development, passive oxygen from the placenta isn't enough anymore, so the fetus needs and gets its own functioning heart. The heart starts forming at week 2 with 2 heart fields and 2 areas of heart's development, the first and the second heart field. At 3 weeks of pregnancy, the heart is first formed as a tube and it initiates a baby's first heartbeat, and by week 4, the heart tube is already able to circulate blood around the fetus's body. At this point, many different types of cells and genes continue to work in the complex development of the full heart. From the heart tube, different genes help to develop an outflow tract and an inflow tract, canals through which the blood can go in and out of the heart. Then at week 4, the developing heart loops on itself as another set of genes work on forming your left and right ventricle and arteries. And eventually, the 4 chambers of your heart, as we see in the adult heart, is completed at week 7. At this point, the baby's heart has also developed valves in its chambers and in the big aortic and pulmonary trunks. These valves ensure proper blood flow and prevent backflow of blood in the heart. The aortic trunk connects the blood from the heart to the body, and the pulmonary trunk connects the blood from the heart to the lungs for oxygenation. In normal development, these heart valves are able to flap open and close as blood passes through. However, in pulmonary atresia, one of these valves, the pulmonary valve connecting your right ventricle and the pulmonary trunk, is closed off or fused. So for babies with this heart condition, they don't exactly follow a normal heart development. In some studies, it starts with the lack of a second heart field at the start of heart development, which causes complications later on in the development of the outflow canal and the vessels. In more recent studies, the embryo may also catch a viral infection or an inflammatory disease at week 4, which then causes a malformation in the pulmonary valve, causing it to fuse after the chambers are formed at week 7. But because the causes of pulmonary atresia remain unclear to this day, there is no exact answer as to how the disorder forms as the heart of the embryo undergoes development.
Now that we know what pulmonary atresia is and how it's formed, the next question is, what causes this rare disease? Well, it still remains unknown, but some plausible theories are quote-unquote inactive genes that can cause babies to have defective pulmonary valves, and viral infections in the mother's body that lead to the inflammation of the heart wall, otherwise known as endocarditis. Next, let's talk about how pulmonary atresia, specifically with an intact ventricular septum, or PAIVS, can affect the other parts of the heart and blood circulation. This is also known as pathophysiology. So in babies with PAIVS, since blood cannot take its normal route to pick up oxygen, alternative routes are crucial for survival. One critical structure involved is the ductus arteriosus, a fetal artery that usually closes a few weeks after birth. However, in babies with PAIVS, this artery must remain open, typically through medication of prostaglandin, as it provides an alternate route for blood to flow from the aorta into the pulmonary artery, allowing for oxygenation. Otherwise, blood can no longer get oxygen, making this condition life-threatening for babies with PAIVS. There are also a few different systems of classification of how PAIVS affects the right ventricle, but we decided to go with this type 1 versus type 2, or the Greenwald classification, since it is the most widely used and arguably simplest to understand. So in type 1, the tricuspid valve is normally functioning. and we know that this valve or flap prevents blood from the right ventricle to flow back into the right atrium. Thus, the blood in the right ventricle gets stuck since it also cannot flow out into the lungs because of defective pulmonary valve. This increases the blood pressure inside the right ventricle, causing its walls to grow thicker. Furthermore, the cavity of the right ventricle itself grows smaller and becomes underdeveloped. So, more often than not, the heart grows abnormal connections between the right ventricle and the coronary artery so that the blood can escape this highly pressurized cavity. These connections are called sinusoids and fistulas. So the implications of this is that the deoxygenated blood from the right ventricle mixes with the blood in the coronary arteries, leading to a less than optimal oxygen supply for the heart. In type 2, or the less common type, the tricuspid valve also has defects. Thus, the blood from the right ventricle flows back into the right atrium. This means that the right ventricle has a relatively normal blood pressure since the blood is not stuck in it. But this also means that the right atrium can become too big or too dilated because of the increased blood volume. So, the blood exits the right atrium to the left atrium through an opening called the foramen ovale, which also leads to a less than optimal oxygen supply for the whole body, similar to type 1.
Now, moving on to symptoms and diagnosis. The first thing parents or doctors may notice is cyanosis, a blue or purple tint to the baby's lips, skin, and nails. This happens because the body isn't getting enough oxygenated blood. Other symptoms include fast breathing or shortness of breath, poor feeding where the baby has difficulty nursing or taking a bottle, and then lastly, the baby is constantly easily tired. These signs often indicate that the baby's heart isn't functioning properly to deliver enough oxygen to the body and can help with diagnosis. Now, in diagnosis before birth, doctors can sometimes detect PAIVS through a routine ultrasound. If there are signs of a heart abnormality, they can perform a fetal echocardiogram, a detailed ultrasound of the baby's heart, to confirm the diagnosis. After birth, there are a few key ways to diagnose this condition. First, a doctor might hear a heart murmur, an abnormal whooshing sound caused by blood flowing irregularly through the heart. A newborn may also show a low oxygen level when taking the newborn pulse oximetry reading. Finally, an echocardiogram is the most important step. This uses sound waves to create a detailed image of the heart, allowing doctors to see the closed pulmonary valve. Together, these symptoms and diagnostic tools helps doctor identify PAIVS early, ensuring treatment can start as soon as possible.
Treating pulmonary atresia usually involves the following: medications, which are given through IV as short-term treatment to keep the ductus arteriosus open and to give patients and healthcare professionals more time. And then we have catheter-based procedures, which involves inserting a long, thin tube in a blood vessel in a baby's groin and guiding it towards the heart. One type is balloon atrial septostomy, which involves using a balloon to enlarge the foramen ovale, or the hole in the wall between the two upper chambers of the heart, which allows blood to move easily from the right side of the heart to the left. Another type is stent placement, which involves placing a rigid tube or stent in the ductus arteriosus to prevent it from closing, allowing blood to keep flowing to the lungs. And then we have surgery, which includes shunting, Glenn procedure, and Fontan procedure. Shunting basically involves making a new route for blood to flow from the heart to the lungs, while Glenn procedure involves letting the right ventricle grow by having a large vein joined to the pulmonary artery and another vein keeping blood flowing to the right side of the heart. Fontan procedure involves letting most of the blood coming into the heart to flow into the pulmonary artery and to the lungs. A recent study by Manham et al. Suggests that pulmonary atresia as a heart defect widely varies, which makes it difficult to have a gold standard treatment. However, both catheter-based interventions and surgery were found to be safe procedures with low risk of complications. In their study, 16 out of 18 patients who underwent catheter-based interventions achieved biventricular circulation, or the normal functioning of the heart where both ventricles work to pump blood. In this group, 6 patients experienced complications within 30 days after initial intervention. These patients also spent fewer days in the intensive care unit or ICU for initial intervention, with 7 out of 18 not even having to be admitted to the ICU. However, they also had a longer hospital stay, ranging from 15 to 36 days. 15 out of 16 patients who underwent surgery also achieved biventricular circulation, with only 3 patients experiencing complications. Although they spent a longer time in the ICU for initial intervention, their overall hospital stay was shorter, ranging from 10 to 20 days.
To conclude, we've explored how pulmonary atresia with intact ventricular septum deviates from normal heart development, wherein the pulmonary valve fails to form properly, disrupting blood flow to the lungs. We've discussed its resulting abnormalities, pathophysiology, and clinical significance, including their symptoms. Understanding these aspects not only aids in early diagnosis and effective treatment, but also highlights the importance of ongoing research into congenital heart defects to improve patient outcome and well being. That concludes our presentation, and we thank you all for your time.